Assalamu alaikum. My name is Dr. Sher Shah, and the topic of today's journal club is bladder pain syndrome. I'm being moderated by Dr. Naveed Mahar, live from SIUT Sakar. So, the topics of discussion would include the definition, history, examination, investigations, and treatment. But before all that, we would like to start with some questions. So, all the patients with bladder pain syndrome have Henner ulcers.
Okay, so bladder pain syndrome is the most ignored topic in urology. Most of us do not go through this topic in detail, and perhaps because it is the diagnosis of exclusion, so we don't have any definitive tools for the diagnosis. So, if any of the residents who has any knowledge about the bladder pain syndrome or interstitial cystitis, if they want to answer these questions, they are most welcome. In case if you cannot answer, just try to attempt it because we are going to discuss all these things later in our presentation.
Bladder pain syndrome is more common in men as compared to women. False, all right. What are the two most common symptoms of bladder pain syndrome? I think yes, pain and polyuria. So, first of all, the definitions. The European Society for Study of Interstitial Cystitis in 2008 stated that pelvic pain, pressure, or discomfort perceived to be related to the bladder lasting at least 6 months and accompanied by at least one other urinary symptom, urgency or frequency, in the absence of other identifiable causes. The American Urological Association states that it's an unpleasant sensation, pain, pressure, and discomfort perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection and other identifiable causes. The European Urological Association 2022 stated that it's the occurrence of persistent or recurrent pain perceived in the urinary bladder region, accompanied by at least one other symptom, frequency or urgency, with no proven infection or other obvious local pathology. So it's a chronic condition. The time duration would be long, 6 weeks or more than maybe 6 months, with unknown etiology, and it's the diagnosis of exclusion. Initial consultation is aimed at generating trust between the patient and the caregiver. Patient should be encouraged to talk about the symptoms and any theories that they have about the origin of the pain. It is important to explain that bladder pain syndrome is a chronic condition with periods of fluctuating symptom severity, where the symptoms may be lifelong. So, history. The most commonly reported regions of pain are bladder, urethra, and vagina. The location of pain and the relationship between bladder filling and emptying should be established. The description of pain ranges from pressure and aching to a burning sensation. Voiding was found to relieve the pain in 57 to 73% of patients, while pain was aggravated by stress, sexual intercourse, constrictive clothing, acidic beverages, coffee, and spicy foods. It is important to include the details of previous pelvic surgeries, urinary tract infections, sexually transmitted infections, bladder diseases, and autoimmune diseases like SLE and Sjogren syndrome. Commonly associated conditions, as we are calling this bladder pain a syndrome, so it's important that there would be other presentations too. Just apart from the bladder pain, there will be other presentations from other systems as well, which might include irritable bowel syndrome, vulvodynia, endometriosis, fibromyalgia, and chronic fatigue syndrome. You should try to rule out the psychological causes like anxiety and depression associated with the pain. Ask for gynecological, gastrointestinal, anorectal, and sexological complaints like post-orgasmic pain with erectile and ejaculatory functions. Should ask for any neurological complaints like sensory loss or dysesthesia. So it's not uncommon for a patient with bladder pain syndrome to say that I go to washroom for 50 times a day. So this frequent urination makes his routine part time. He's not a full time person. If he has to go to work, he would be looking for washroom, or he would go in the places where the washroom would be near, or it would be easy for him to go to mixture it. So all this problem makes him a part time man. The pain is mostly located in the suprapubic region. The pain is aggravated during intercourse, and in women, there are more intense symptoms during menstrual periods. And we know that all these symptoms are arising without any infection. So there are no infections, no pathogens detected in the urine.
In some of the literature, it is stated that there are no storage symptoms like nocturia or frequency. If these symptoms are absent and the rest of the symptoms are present, we cannot label that as a bladder pain syndrome. So frequency and nocturia are the most important and main symptoms for diagnosis of the this syndrome.
Yes. So before examining the patient, the basic rules are we all know. We have to introduce ourselves, tell the patient why are we examining him. We have to expose him, proper exposure from umbilicus till mid thigh, and then we have to do the all the steps, including inspection, palpation, percussion, auscultation, followed by the genitalia examination, digital rectal examination, followed by covering the patient and saying thanks, which is very important. So the specific points in examination, we have to rule out bladder distension due to urinary retention, hernias, and painful trigger points on abdominal examination. Genital examination to rule out atrophic changes, prolapse, vaginitis, tender trigger points over the urethra, vestibular glands, vulvar skin, or bladder, and for features of dermatosis. An evaluation of the introitus and tenderness during insertion and opening of the speculum should be made. Superficial and deep vaginal tenderness and tenderness of the pelvic floor muscles and gluteal muscles should be assessed during the course of examination. A bimanual pelvic examination is helpful to rule out cervical, adnexal, or abdominal pathology. Neurological testing for sacral reflexes, sensory responses, and muscle functions should be carried out. So next would be investigations. Frequency volume chart, 3-day fluid diary with input and output is useful in initial assessment. Patients with BPS classically void small volumes, so this is useful to identify the severity of storage symptoms. The first morning void is a useful guide to the functional capacity of the bladder. Incomplete bladder emptying should be excluded by post-void residual bladder scans, and frequency volume chart can be used to reinforce behavioral strategies and, where necessary, pharmacological treatments. Urine culture and sensitivity, we should look for acid-fast bacilli in cases of sterile pyuria. And if we have a negative urine culture with pus in the urine, we should also investigate for urinary ureaplasma and chlamydia. Other causes of sterile pyuria can be bladder stones, partially treated UTIs, and carcinoma in situ of the bladder. Incomplete bladder emptying should be excluded by post-void residual bladder scans and urine cytology to rule out malignancy. Urinalysis can be used to look for the color, odor, or blood in the hematuria. We can detect the presence of all these pathogens, and then we can go for cystoscopy. When we introduce the cystoscope into the bladder is filled with sterile water or caseal solution. So this hydrodistension would cause pain, which is diagnostic for bladder pain syndrome. And patients with bladder pain syndrome have reduced maximum filling total capacity. So in cystoscope, when you look at the bladder, there's this urothelium, the transitional epithelium. We all have heard of the washerman hands when a man uh, keeps on washing his hands become all soggy and dried up. So this is because your skin cannot like resist water. The water gets into your skin and then damages the underlying structures. But urothelium, the transitional epithelium, is not like that. It is made to resist the water. It does not let it pass through. So the outermost layer here is the mucin layer, which is the protective covering of the urothelium lying down. So this mucin layer contains the glycosaminoglycans, chondroitin sulfates, and all those connective tissues that are helpful. So initially, there are theories like autoimmune, neurologic, or infections. There can be genetics involved. There can be allergies or stress, which causes the disruption of this healthy glycosaminogag layer, the mucin layer. So what happens is the urine gets through this mucin layer and goes into the urothelium and starts irritating this urothelium. Here you can see the defects in mucus layer allow solutes to penetrate the bladder wall to cause glomerulations and pain. These glomerulations are kind of petechiae that you can see over the urothelium, and it all happens because the glycosaminoglycan layer, the protective layer of the urothelium, is defected. So in cystoscope, we can have these two kinds of findings. First of all, there can be glomerulations, and then there can be Hunner's ulcers. There are distinct inflammation on the bladder wall, which occur in 5 to 10% of the cases. So within these glomerulations, an ulcer arises, which can be seen on the cystoscope. So here you see the spiral arteries or comparatively dilated small arteries that you can see on the cystoscope. These are glomerulations, or they can start bleeding after hydrodistension or without hydrodistension. These glomeruli are bleeding. And then within these glomerulations, these ulcers arise, which can be seen on cystoscope. And these are called the Hunner ulcers.
It takes a lot of experience to diagnose these Hunner ulcers on cystoscopy because most of the time we can just get carried away with the hyperemia of the bladder mucosa. So it is very important and very lot of experience is required once you can be able to differentiate between the hyperemia and these Hunner ulcers on cystoscopic findings. So cystoscopy. We all of our residents perform cystoscopy most of the time without supervision, and this is the one basic examination, and it requires a very vast experience to diagnose all these things because it is not just simple like X-ray KUV kind of thing that you just put a scope inside the bladder and you will be able to see and appreciate everything from the beginning.
Now, just to add a little bit with what you have been saying and displaying here, not only experience, but it also needs a little bit of commitment as well as kind of an interest that happens whenever somebody reads a lot. Reads a lot means, for instance, when I was a very junior person, at that time again, cystoscopy was something which was unsupervised. Nobody was there to guide anyone. But again, if an instrument is in your hand and a patient is in front of you and the patient is anesthetized, and the commitment is that there is a question and you want to know the answer, then you have to read something, what you want to see in the bladder. Now, there are certain ulcers that weep when you try to deflate the bladder after inflating, but there are certain ulcers which are there when you are starting to just inflating the bladder. So there are two kinds of ulcers, and if you go along with your own experience and your own learning curve of seeing the bladder from inside, ulcers are two types. One comes up when the bladder starts filling, and the other one comes up when it starts deflating. So it's a very interesting kind of not only of a subject, but also an interesting learning curve for every one of us.
Right. And then among investigations, we have video urodynamic studies, which is done in cases of coexisting bladder pain syndrome and overactive bladder, stress urinary incontinence, and voiding dysfunction. And then this is very important. You should have a validated symptom score on the basis of which you will judge the symptoms and your treatment. Uh, there are three published bladder pain syndrome symptom questionnaires: the University of Wisconsin IC scale, the O'Leary Sant IC symptom index, and the pelvic pain and urgency frequency scale. So the University of Wisconsin IC scale includes 7 bladder pain syndrome or interstitial cystitis symptom items, which include pain, discomfort, burning sensation, daytime frequency, nocturia, urgency, and difficulty in sleeping. It captures severity of the symptom expression, addresses some quality of life issues. It is easy to implement but not validated for identification and diagnosis of bladder pain syndrome. Then comes the O'Leary Sant IC symptom index. It is subjected to test retest reliability analysis validated by administration to IC patients and asymptomatic controls, centered on 3 questions related to urgency frequency and 1 question on bladder associated pain. So this is the chart. So the O'Leary Sant symptom and problem index includes 4 questions for the symptoms and 4 questions for the problem index. So there are different questions. Should I read them all? So the first question, symptom index, is how often have you felt the strong need to urinate with little or no warning? So there are 5 answers, including not at all, less than 1 time in 5, less than half the time, about half the time, more than half the time, and almost always. The second question is, have you had urinate less than 2 hours after you finished urinating? The third question is for nocturia. There's once, twice, thrice, 4 times, or more than 5 times. And have you experienced pain or burning in your bladder, which says not at all, a few times, almost always, fairly often, and usually. And then we have these questions for the problem index, the frequent urination during the day. Is it a problem, no problem, very small problem, medium problem, or big problem? So these are all the things which this is a questionnaire that you have to give to the patient, and he will fill them up. Getting up at night to urinate, does this cause a problem? Need to urinate with little warning, is it a problem? Burning pain, discomfort, or pressure in your bladder, is this a problem? Very small problem, a medium problem, or a big problem? So you have to add these symptom and problem index scores. So greater than 6 suggests that interstitial cystitis syndrome is possible, whereas if the score is more than 12, it strongly indicates in the favor of the diagnosis. And then we have this PUF scale, the pelvic pressure and urgency frequency scale, which includes questions that directly reflect a wide variety of symptoms. 1/3 of the questions addresses pelvic pain. A large study utilizing the PUF questionnaire concluded that almost 23% of the American females have interstitial cystitis. But of course, it also faces the validity and utility in question. We have this PUF questionnaire. We have given these 4 points from 0, 1, 2, 3, 4, and these 8 questions. So how many times do you go to the bathroom during the day, which is frequency? 3 to 6 is give 0.1, 7 to 10 is 3 to 6 is 0, 7 to 10 is 1, 11 to 14 is 2, 15 to 19 is 3, and 20 plus times is 4. How many times do you go to the bathroom at night? Nocturia, 0, 1, 2, 3. If you get up at the night to go to the bathroom, does it bother you? So previously in O'Leary Sant score, we saw there were symptom and problem index. Here we have the symptom score and bother score. So there are four questions which would tell about the bothersome of the issue of the symptom, and the other questions are related to the symptoms. So the patient is currently sexually active. If you are, if, do you now have or have to ever had pain or symptoms during or after sexual activity? It's never, occasionally, usually, always. If you have pain, does it make you avoid sexual activity? Same, never, usually, occasionally, and always. Do you have pain associated with your bladder in your pelvis, bladder or in your pelvis? That would be vagina, labia, lower abdomen, urethra, perineum, penis, testes, or scrotum. If you have pain, is it usually mild, moderate, or severe? Does your pain bother you? Do you still have urgency after you go to the washroom? And if you have urgency, is it usually mild, moderate, or severe? And does your urgency bother you? So all these questions you have to ask to the patient, and then add the symptom and the bother score. So a total puff score of 15 or greater was associated with 84% likelihood of having the disease. Then comes the treatment.
Now, before going into the treatment, I would like to have an opinion or a comment from Naveed. Naveed, this the O'Leary chart and this one, the puff chart. Both these charts have got questions that need a little or more of a privacy, which is not possible in a very busy clinic where there is no provision of a separate kind of a room where you can talk to your patient. Because for these questions, even if um, a provisional kind of a doubt exists in your mind as a clinician that your patient has got some problem related to interstitial cystitis, these questions cannot be asked very frequently or very easily. So they need a little bit of confidence to be built up between the patient as well as yourself as a clinician. So, what's your opinion?
Exactly, sir. You are absolutely right. When we started our functional urology clinic initially, the first problem was that we were all male patients, a male doctor, and to build a communication between our female population and a male doctor, so that female can explain all these questions in such a busy clinic, was a very big problem. But fortunately, when Dr. Shiri joined our team, this problem of all the male doctors got resolved. But indeed, we need some sort of a separate cubicle where we can give space to patient where we suspect such kind of disease, and clinician do get some time to interact with them in some private place so that they can honestly answer all these questions. And we have a very busy clinic, so usually we don't provide time to our patient as well. It's just not privacy, but time is also issue. These patients require more time, more attention, and a less communication gap so that they can build a trust over clinician, and then they can answer these questions and we can reach a conclusion. So this is definitely a problem. We need to work upon that and find some sort of solution so that we cannot lose these kind of patients.
Right. And if you ask your colleagues or your juniors that how many patients of interstitial cystitis um, have you seen in the last 3 years of your training, or maybe in 20 years, if the person has to be happens to be a very senior person in 20 years of clinical practice, maybe the answer is that they haven't seen a single patient of interstitial cystitis. The reason being that there is a very wide gap. For instance, if you happen to go to the West, maybe to Australia, UK, in any European country or in America, as you have said in the previous slides, the percentage of occurrence of this kind of a problem is like 23% in females, and and this is very true because I've got a very small experience of going out, and in 10 patients in the ward, two of them on an average are with this kind of a problem, male or female. That doesn't make any difference. So this is so common in that geographical area. Why? uh, to me, it is just because the reason that we in our part of the world haven't been too much into the practice of asking questions, building up confidence with the patient, and committing ourselves to any problem solving. For instance, if somebody comes to me with this kind of a symptom complex, I would rather go towards my back of my mind, asking myself whether this patient is in, if happens to be a male patient, if this is a BPH group or not, straight away. So I would not like to think in terms of other things related to bladder pain syndrome. So the same applies to a female also. So we need to revisit this subject together. Together means junior, seniors, all of us in the community of doctors in urology, because this problem does exist in our population. In India and Pakistan, I haven't seen many papers coming up with this kind of a problem, as if this doesn't exist. I don't think so. We have to give a little bit of more time to these patients so that they can come up with their problems in detail.
Uh, exactly, sir. I can recall there was one to two patients who almost visited almost every clinic every week in our clinic with all sort of these problem, but we never asked them and we never thought about this condition. As I already explained in first slide, that this is the most ignored topic by all of us. Maybe because we don't read about it, maybe because we don't have that much time due to this busy schedule. But this is right. We need to look at our practices, and we need to read more about this, and we need to communicate with the patient, because it is not possible that this kind of problem does not exist in our population. But it is just we are ignoring those patients, maybe. And sometimes we get annoyed with the those patients because we see them almost every day coming to us. So definitely those patients are in problem. This is why they take out their time and they visit the hospital, and then even after we scold them, they just don't go away because their problem is not letting them sit at their home. So we need to relook our practices, and we need to find some solution for all these patients as well.
Right.
Moving on to the treatment. So first of all, the conservative management, which includes dietary modification, stress management, and exercise, acupuncture, simple analgesics like paracetamol, ibuprofen, and opioids. And primary management option, it is a primary management option and usually should last for 3 to 6 months before moving on to the further interventions. So support groups of including the psychologist, the pain management team, and a physiotherapist, all of them are very important. We have to avoid tea, soda, chocolate, coffee, citrus fruits, or any other acidic foods, alcohol, soy, MSG, and spicy foods. The pelvic floor muscle training is very important. You see, all these pelvic muscles are supporting your bladder, your uterus, the bowel. All the pelvic organs are being supported by these muscles. So these muscles need to be very strong, and you should ask your physiotherapist or to tell you that what kind of exercises that you can do. So the bladder pain syndrome medications, we've talked about the simple analgesia, including brufen, opioids, or paracetamol. And then we have this tricyclic antidepressant, amitriptyline, which can be used, and it's also safe in pregnancy. But you should know about the harmful effects, which include dry mouth, weight gain, constipation, sedation, and blurred vision. And then we have these bladder installations through catheter. So these bladder installations include lidocaine. As we all know, it would block your sensory nerves. The hyaluronic acid, Botox, dimethyl sulfoxide, heparin. Heparin is also safe in pregnancy, and then the chondroitin sulfate. So all these substances are instilled into the bladder mucosa for relief. So these would cause healing of this mucin layer so that the urine could not seep through this layer into the urothelium and cause pain and problem. And this increased urinary frequency can be managed by using anticholinergics. So, here I've tried to make this diagram. This is showing your bladder, this trigone, and the urethra. So first of all, what we need to do is provide some kind of a pre-leaf. So you have to alkalinize your urine, reduce its acidity. So you'll give calcium glycerophosphate 2 tablets before meals to first of all alkalinize this urine. So, and all the urine that gets collected into the bladder, first of all, goes down in the most dependent part, the trigone region. So, this is the area which is most commonly affected and most frequently affected. And your lesions, the Hunter lesions, glomerulations, all these you can find more near to this area of trigone. And when you go back to the embryology, you know that the proximal 1/3 of the vagina is formed by your Mullerian ducts, whereas the distal 2/3 of the vagina is formed by urogenital sinus. So this urogenital sinus also gives origin to the bladder. So estrogen is a hormone that acts on your vagina, and then subsequently there are receptors because of the same embryological origin which are found in your bladder. So estrogen is very important. You can give estrogen in the local topical forms, or you can give them orally to first of all make your trigone healthy. And then in these bladder wall, there are expressions of mast cells, just like in your nose, which can be blocked by antihistamines. And the patient with bladder pain syndrome also secrete this anti-proliferation factor. This anti-proliferation factor does not allow this mucin layer to heal. So we have a pentosan sulfate, which is similar to heparin, called Elmiron, which is used to block this anti-proliferating factor, and hence the mucosal layer of the bladder gets easily healed up. And the patients who feel pain, you know, the sensory nerves go right from the bladder to the brain, and then the motor nerves come from the brain into the bladder, which can cause this urgency and frequency. So our brain trains up. It trains up in knowing in the memory of the pain. So the more pain you would feel, the more instances of pain you would feel, there will be more memory in your brain that would sense this pain sensation. So every time a patient moves, the nerves get stimulated. There is a gush of sensory nerves that goes into the brain, and it causes the patient to like rush into the washroom. So we have to have the periods when the patient is symptom free, so that his memory inside the brain gets less, and he could feel the sensation less often. So we have this percutaneous tibial nerve stimulation, which gives the periods of rest. So a patient thinks for some time that he's not having pain, so this his memory inside the brain just goes off. And then these urgency frequency symptoms coming from the brain, the motor symptoms, are blocked by anticholinergics like detrocytol and butane. Then we have the same neuromodulators, which can be through sacral spinal nerves, and then they go on to the pudendal and perineal nerves. They're also very helpful, but you do not use them in pregnant female. So this decreases the frequency quite a lot, and gives the sensation of that the pain is gone. Oral cyclosporin is an immunosuppressive drug that we mostly use in transplant patients. It may be considered if conservative, oral, intravesical instillations, and neuromodulations. If all these have failed, then you can go for this oral cyclosporin. Patients treated with low dose cyclosporin showed improvements in bladder capacity, voiding volumes, pain, and decreased urinary frequency. However, symptoms recurred by therapy cessation. Side effects include hypertension, gingival hyperplasia, and facial hair growth. And then we have these surgical procedures, which should be used as a last resort. We can just remove the bladder by this supratrigonal cystectomy with urinary diversion. It is used as a last resort. It's an invasive procedure and it doesn't guarantee relief. So you have to tell the patient it's very important that even if you go through this surgical procedure, it is possible that the pain may persist throughout the life. And then we have these active bleeding glomerulations or Hunner ulcers. They can be fulgurated using lasers. The EUA recommendations for diagnostic evaluation. So you have to perform the rigid cystoscopy under general anesthesia to subtype and rule out other confusable diseases. This is what European Urological Association says. You have to assess BPS-associated non-bladder diseases systematically. You have to assess BPS-associated negative cognitive, behavioral, sexual, or emotional consequences, and use a validated symptom and quality of life scoring instrument for initial assessment and follow-up. And then we have EUA recommendations for management, which include you always have to consider offering multimodal behavioral, physical, and psychological techniques alongside oral or invasive treatments. Amitriptyline can be used, but do not use long-term steroids. Offer submucosal bladder wall and trigonal injections of Botox plus hydrodistension if intravesical installations, the other installations have failed, and only take ablative organ surgery as a last resort. Thank you for listening.